ഹലോ ഐശ്വര്യ, മാഡം നോക്കിയല്ലോ അല്ലേ? ചെക്ക് ചെയ്തല്ലോ അല്ലേ?
സ്ലൈഡ് നോക്കി മാഡം.
ഓക്കെ, ഞാനപ്പം ഒന്നും കൂടെ ഇടട്ടെ, ഗ്രൂപ്പിലൊക്കെ ഒന്നും കൂടെ ഇടട്ടെ. ഇപ്പൊ സ്ലൈഡ് കാണുന്നില്ല. ഒരു സെക്കൻഡേ.
കാണാമോ മാഡം? ഇപ്പൊ കാണാമോ?
കാണാം കാണാം കാണാം. ഇന്നലെ മഴയായി പോയല്ലേ?
ഭയങ്കര മഴയായിപ്പോയി. അതിന്റെ മാഡം മൂവ് ചെയ്യുന്നത് കാണുന്നുണ്ടല്ലോ അല്ലേ?
മൂവിന്ന് കാണുന്നുണ്ട്. ഞാൻ ഒരു മിനിറ്റ്, ഞാൻ ഇപ്പൊ തന്നെ ഒന്നും കൂടെ ഷെയർ ചെയ്താലേ പിള്ളേര് അൺയൂഷ്വൽ ആയതുകൊണ്ട് ക്ലാസ്. ബിജോൺ സാർ കേറി കേട്ടോ. ബിജോൺ സാർ കേറിയിട്ടുണ്ട്. ഇപ്പോഴും പ്രശ്നങ്ങൾ ഉണ്ടെന്ന് തോന്നുന്നു എല്ലായിടത്തും അല്ലേ? പക്ഷെ എനിക്ക് ശരിയായിട്ടില്ല റേഞ്ചൊക്കെ.
റേഞ്ച് ഒക്കെ ആയിക്കൊണ്ടിരിക്കുന്നതേ ഉള്ളൂ. സോ ഫാർ സോ ഗുഡ്.
അതെ അതെ അതെ, അതെന്തായാലും മാഡം രണ്ടാമത് റീകണ്ടക്ട് ചെയ്ത് നന്നായി. ഇപ്പൊ കുറച്ചു പേർക്ക് കൂടെ അത് എടുക്കാലോ. അപ്പൊ എനിക്ക് തോന്നുന്നു സാറുണ്ട്. ഞാൻ ആക്ച്വലി ഡ്യൂട്ടിയിലാണ്. അപ്പൊ ഞാനിപ്പം ജസ്റ്റ് അപ്പം ഇന്നലെ മാഡത്തിന്റെ ക്ലാസ് എനിക്ക് കയറാൻ പറ്റിയില്ല. വെരി ഹാപ്പി ദാറ്റ് മാഡം എഗ്രി ടു ടേക്ക് ക്ലാസ്. കാരണം നമ്മൾ ലാസ്റ്റ് പറഞ്ഞിട്ടും ക്ലാസ് എടുക്കാൻ സമ്മതിച്ചതിൽ വെരി ഹാപ്പി. പിന്നെ അപ്പൊ ഓൺ ബിഹാഫ് ഓഫ് IMA അത് വലിയൊരു താങ്ക്സ്. എന്തായാലും നമ്മുടെ ക്ലാസ്സസ് റെക്കോർഡഡ് ആണ്. അപ്പം ലാസ്റ്റ് മിനിറ്റ് ആയതുകൊണ്ട് കുട്ടികൾ ദേ ആർ റിപ്പീറ്റഡ്ലി വാച്ചിങ് ദിസ്. സോ അപ്പൊ നമുക്ക് ബാക്കിയും കൂടെ ചെയ്യാം മാഡം. ബാക്കിയുള്ളവർ ജോയിൻ ചെയ്തോളൂ. തുടങ്ങാം മാഡം.
നമുക്ക് സ്റ്റാർട്ട് ചെയ്യാമോ?
യെസ് 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 യെസ്, റെക്കോർഡഡ്.
Okay madam, sure. Okay, good evening. I'm Dr. Meenu once more. I'm sorry, rain kind of wreaked havoc yesterday with our class. So we'll be taking up where we left off yesterday. We have a 52-year-old menopausal female who presents with a single episode of postmenopausal bleeding. A vaginal scan that has been done shows endometrium with uniform thickness of 3 millimeters. What is the most appropriate step in management? And you've got the choices there. Before we go into the details, I would just like to recollect you what are the causes of postmenopausal bleeding. The most common cause of postmenopausal bleeding is endometrial atrophy. This is followed by hormone replacement therapies, endometrial polyps, endometrial hyperplasia, and even carcinoma of the endometrium. So that is not what we want here. You want to know the management of postmenopausal bleeding. Menopause means you've got cessation of menses for at least 1 year, and any bleeding that occurs after that requires evaluation, even if it is the first episode. Okay? So whenever a woman presents with postmenopausal bleeding, the first investigation that you do is always a transvaginal sonogram. This is done to measure the endometrial thickness, and it is based on the endometrial thickness that the further management comes. Suppose the endometrial thickness is less than 4 millimeters. Whenever you find that the endometrial thickness is less than 4 millimeters, in a person who is presenting with postmenopausal bleeding, your diagnosis is, in all probability, this is an endometrial atrophy. You will ask her to review after 3 months or earlier if the bleeding occurs. If the endometrial thickness is 5 millimeters or more, in that case, you have to change. The investigation of choice becomes an aspiration biopsy. You must have seen an aspiration biopsy. This is done with a Pipel cannula or a Karman cannula or a vacuum aspirator. All right. Endometrial thickness 5 millimeters or more. The investigation of choice is an aspiration biopsy. But this is the investigation of choice. But if you're asked what the gold standard investigation is, your answer changes. The gold standard investigation is a fractional curettage. Now you find that the endometrial thickness is 4 millimeters or more. But there is a focal area of thickness. Whenever you get a question that mentions a focal area of thickness, your answer has to, or your diagnose, you have to train your mind to think in terms of an endometrial polyp. In that case, your investigation of choice changes. The investigation of choice will be a hysteroscopy and biopsy. Hysteroscopy with a biopsy. But even though your investigation of choice changes, the gold standard investigation remains the same. The gold standard investigation is a fractional curettage. Do you get this? Postmenopausal bleeding. First investigation is a transvaginal sonogram for endometrial thickness. Endometrial thickness less than 4 mm. Review after 3 months. 5 millimeters or more. Investigation of choice is an aspiration biopsy. Gold standard is FC. 4 millimeters or more with a focal area. A focal area, the investigation of choice is hysteroscopy with biopsy. Gold standard remains fractional curettage. Okay. Now, why do we choose 4 millimeters? 4 millimeters means in a woman, the most important diagnosis that you have to consider in postmenopausal bleeding is carcinoma of the endometrium. So if the endometrial thickness is less than 4 millimeters, it means that there is very low chance, just around a 3% chance that this woman may have a CA endometrium. That is why we have taken the cutoff to be 4 millimeters. Okay. Let's look at the question once more. 52-year-old woman presents with postmenopausal bleeding. Endometrial thickness is 3 millimeters. That is, it is less than 4 millimeters. So what do? Not a fractional curettage, not hysteroscopy, not Pipel. You'll ask her to review in 3 months or earlier if bleeding occurs. Coming to the next question, which histological type of CA endometrium has the best prognosis? Multiple histological types are given in the choices. The answer is endometrioid adenocarcinoma. Let us just look at the types of endometrial cancer. You've got type 1 and type 2. Type 1 is the cancer that has got a slightly better prognosis than the other type 2. Type 2 is the one that is seen in postmenopausal women. It is aggressive, and it includes all the non-endometrioid cancers. Non-endometrioid cancers means the papillary serous variety, the clear cell cancers, the squamous cell carcinomas, all the non-endometrioid varieties. You have to think in terms of that. Type 1 is the one where you've got the endometrioid cancer, and this one carries a better prognosis as compared to type 2, which has got a worse prognosis. It is an aggressive cancer. Another thing that you have to note here is type 1 cancer is seen in pre- and perimenopausal age group, while type 2 is seen in postmenopausal age group. And what is the gene mutation? Type 1 comes with a P10 mutation, while type 2 is the one with the P53 mutation. Okay. Carcinoma endometrium with positive superficial inguinal lymph node status is classified as which stage? I'm sure you all know the answer to this one. It is stage 4. Now, this one here, what I've given here, this is the previous FIGO classification of carcinoma endometrium. Carcinoma endometrium classification has changed. We have got a new classification that has come up in 2023, which includes multiple, something called a Paul mutation. I don't know whether you're aware of the Paul mutation. Paul is polymerase epsilon. And since now we are going in for immunotherapy, the Paul mutations have come to be very important. Probably this is the one that you have learned before, but the staging has changed. And this is the new staging. Again, you see that it is in stage 4 that you've got the lymph node metastasis. What has changed is now it has got a 4C. The latest staging, the latest FIGO staging of carcinoma endometrium comes with 4C. Previously, the staging was only up till 4B. Now it has got 4C, and the lymph nodes come under 4C. Intra-abdominal lymph nodes all come under 4C. I hope this is clear. I want to make this very clear to you. In the new classification of CA endometrium, there is a further stage, that is 4C, where the lymph nodes come into play. Okay, I hope that is clear. Anyway, your question was superficial inguinal lymph node, which stage? They have not given subtypes like 4A, B, or C. They have just given stage 4. So your answer is stage 4, but note that just 4C and not 4B as it was previously. An 80-year-old female who has never taken estrogen develops pink vaginal discharge. The endometrial biopsy shows adenocarcinoma of the endometrium. Pap smear is negative. Of the following, what is the most important indicator of prognosis? What are the most important prognostic factors? As far as prognostic factors are concerned, the most important of all the prognostic factors is the stage of the disease. Stage. But here in the choices, the stage is not given. This is followed by the lymph node involvement. And that is followed by the histology. Since lymph node involvement is also not given, here you have to choose your answer as the histologic type of the tumor. Let's go through that once more. The most important prognostic factor is the stage, which is followed by the lymph node involvement and then the histology. Okay. What are the other prognostic factors? You've got age, then the invasion of the myometrium, cervical extension, the size of the tumor, the hormone receptor status, the ploidy, oncogene expression, all those are there. But you cannot mug up all those things. But this you have to remember, the most important prognostic factor is the stage of the disease, followed by the lymph node status, and then the histology. All right. Going on to the next question. The following are indications of post-operative RT in a case of CA endometrium except. Now, all these are the indications for adjuvant radiotherapy in a case of CA endometrium. What are those? Extrauterine extension, lower uterine or cervical involvement, papillary serous or clear cell histology, as we discussed before, a non-endometrioid histology. Poor histologic differentiation, myometrial penetration more than 50%, and pelvic lymph node involvement. Now, to summarize this one, I'll just say this. Only 1A, grade 1 and 2, need no post-operative RT. Okay, so you study what 1A is, what grades 1 and 2 are. These are the only ones that do not need a post-operative radiotherapy. All the others will definitely need a post-operative RT. That is how you can easily arrive at your answer. You've got positive lymph nodes, if there is cervical involvement, if the tumor is positive for estrogen receptors. All those are indications for post-operative RT, except for stage 1A, grades 1 and 2. And now we've talked about radiotherapy. You know that radiotherapy is important for almost all cancers of the uterus and the cervix. What about chemotherapy? Is chemotherapy used in CA endometrium? Yes. Where is it used? Chemotherapy in CA endometrium. It is used in stages 3 and stage 4. And what is the chemotherapeutic regimen? It is the TAP regimen. What is this TAP? TAP stands for Taxol. T is for Taxol. What is Taxol? Paclitaxel. A is for adriamycin or doxorubicin. And again, you've got P. P is for platinol. What is platinol? cisplatin. Okay, don't confuse in between. You've got Taxol, adriamycin, and platinol. That is paclitaxel, adriamycin, cisplatin. That is a chemotherapy which is used for carcinoma of the endometrium, and that is for stages 3 and 4. All right. So that is it with regards to CA endometrium. You have looked at the prognostic factors. We have looked at the staging. You have known the radiotherapy and the chemotherapy. Next question. A 32-year-old woman presents to a gynecologist for routine checkup. She has been regularly screened for cervical cancers with pap smear since the age of 21. Her last pap smear performed 3 years ago was normal. She is in a monogamous relationship and has no significant medical history. Her gynecologist suggests that given her age and screening history, she could now undergo a primary HPV DNA test as part of a cervical cancer screening. Which of the following is the most appropriate next step in her cervical cancer screening? Now, when is cervical cancer screening done, or what is the importance of cervical cancer screening? What is a causative agent for cervical cancer? It is human papillomavirus, HPV. HPV 6, 11, 16, and 18. These are the most important ones. Which are the HPVs? 6, 11, 16, and 18, where 16 and 18 are the ones that are most important in causing cervical cancer. 16 for squamous cell carcinoma and 18 for adenocarcinoma. Anyway, 16 and 18 are the most important ones. So, since the HPV vaccine is becoming more and more prevalent, we always go for instead of a routine pap smear, these days we are more in favor of an HPV screening. When do you screen for HPV? And HPV testing is done 5 yearly in every woman between the ages of 21 and 65. Right? You do not repeat pap smear alone. If it is a conventional pap smear that is done, usually it is repeated every 3 years, not every year. Co-testing with pap smear and HPV DNA every 3 years? No, this is also not indicated in a woman who is low risk. How do you know she is low risk? She's up to date with her pap smear. See, her last pap smear was done 3 years ago and she is in a monogamous relationship. That means she is a low risk patient. So she does not require co-testing. Pap smear and colposcopy, when is it done? It is done only if there are any abnormal results, abnormal findings on the screening. So here in this case, the answer is primary HPV DNA testing alone every 5 years. When did we say this is done? Between 21 and 65 years in a low risk woman, a woman in a monogamous relationship who does not have any other risk factors. But if you're asked, when is the pap smear repeated every year? If the pap smear or HPV DNA, when has it to be repeated every year? That is usually done when she's immunocompromised in polygamous relationship or when the woman is HIV positive. When she's HIV positive, it is better that the pap smear is repeated every year instead of every 3 years. All right. This is another important topic with regard to HPV testing. How often do you do it? All right. Coming to the next question. A 62-year-old woman presents with postmenopausal vaginal bleeding. On examination, there is a friable mass visible on the cervix. A biopsy is performed. Histological image is shown below. Following the biopsy, further imaging studies reveal the tumor has invaded into the parametrium, but has not extended to the pelvic wall or the lower third of the vagina. Based on the histologic findings and imaging studies, what is the most appropriate FIGO stage for the patient's cervical cancer? You've already got the diagnosis. They've also helped you with this. It has invaded into the parametrium, not extended to the pelvic wall or the lower third of the vagina. This is stage 2B. This is the cervical cancer staging. Right before the exam, immediately before the exam, it is advisable that you go through the staging of the FIGO staging of the cancers. After all, it is endometrium, cervix, and ovary. At least these 3 cancers, you just go through. I think choriocarcinoma is pretty easy. You'll be able to remember it easily. But these 3 cancers, cervix, endometrium, ovary, just go through the FIGO staging. Something will stick in your mind and you will be able to arrive at your answer. You might think that this is very difficult. Yes, by hearting staging is not easy, but if you go through it 3 or 4 times, something or the other will stick in your mind, and from the question you will be able to, from the question you'll get clues so that you'll be able to arrive at your answer easily. Okay. Question 28. Which of the following is not an indication for corn biopsy? What is corn biopsy? Corn biopsy, or also known as cornization. What is cornization? This is a standard for evaluating an abnormal, it used to be the standard for evaluating an abnormal smear. Now, if you're asked, how do you evaluate an abnormal smear? Now, your best answer would be colposcopy. Colposcopy is preferred over corn biopsy or cornization. Anyway, before the advent of colposcopy, corn biopsy or cornization was the standard for evaluating an abnormal smear. When is it done? What are the indications? What are the indications for corn biopsy? Let us just go into the indications. First one is you're trying to evaluate or take for a smear, but the limits of the lesion are not visible. That is, the lesion is extending into the cervical canal. See, here you've got your cervix, and this is the os. And if you have got a lesion here, then it is quite easy. You do not need a corn biopsy. You can take something, if you're going for a cervical biopsy, or if you're going for a VR testing, you can take it from here. But suppose the limit of the lesion is not visible. This is the os, and the lesion is here, and you're not able to clearly demarcate where the lesion ends. It is going inside the canal. Then you will have to go for a corn biopsy. That is one. Next thing is the squamocolumnar junction. You're not able to visualize the squamocolumnar junction. Again, you have got an endocervical curating that is positive for CIN 2 or 3. Then you have done cytology, but there is a lack of correlation between the cytology and the biopsy. Or you're suspecting microinvasion or endocervical glandular atypia. Again, this seems like a lot of things, but here, look at the choices. You have got a suspicion. As far as a corn biopsy or cornization is concerned, you're going into the endocervical canal. So just look at the areas where you need to go into the endocervical canal, and you can come and get your answer. Yes, if you've got a suspicion of endocervical glandular atypia, you need to take a sample from inside the endocervical canal. So that is an indication. Squamocolumnar junction is not seen. What does that mean? It has also gone into the canal, another invasion. If you're suspecting a microinvasion, definitely you need a corn biopsy. Again, as we said, you cannot correlate, you need a corn biopsy. You have got endocervical curatings that are positive for CIN 2 or 3. Again, you'll have to go in for a corn biopsy. But in the case of an invasive squamous cell carcinoma cervix, there is no role of corn biopsy. Next question. A 25-year-old woman presents to the gynecology clinic with complaints of intermittent lower abdominal pain over the past 2 months. The pain is worse on the right side and is not related to her menstrual cycle. She denies any fever, nausea, or abnormal vaginal discharge. On physical examination, there is mild tenderness in the right lower quadrant without rebound or guarding. A TVS reveals a 5 centimeter unilocular thin wall cyst in the right ovary without any solid components or septations. So you got the ultrasound picture there. What is the most appropriate initial management for this patient? In questions like these, you look at the question, it is quite a long question. So there will be many distractors. The thing is, the important thing for you is to pinpoint on what the important points are. When you go through this once, you find that this is with regard to an ovarian cyst. Whenever it is in regard to the ovarian cyst, even before looking at the ultrasound features, the first thing that you have to look at are the symptoms. She has got intermittent lower abdominal pain. And she doesn't have fever, nausea, she doesn't have anything of that. So she has got mild tenderness, no rebound, no guarding. Okay, these are her symptoms. Now you look at the scan. The size of the cyst is the first thing that comes up. It is 5 centimeter. It is unilocular. It is thin walled. It does not have any solid components or septations. All these are important as far as an ovarian cyst is concerned. Look at that picture. It is a clear cyst. Now, you don't see anything inside, right? So Ovarian cyst management depends on two things. Mainly, it depends on whether the woman is menopausal or premenopausal. That is the first thing you have to look at. So she is a 25-year-old girl. Next off, you look at the tumor markers. Whenever you find an ovarian cyst, you will send for tumor markers. But tumor markers are more important in case of a post-menopausal woman. I believe you know this term. There is something called RMI, which is the risk of malignancy index, where you have got an ultrasound score, menopausal score, and CA125 value. Ultrasound, menopausal score, and CA125. These are the components of RMI. Anyway, this is more important for a post-menopausal woman. Here, what we have is a premenopausal girl. She's 25 years old. In that case, we immediately look at the size of the cyst. If the size of the cyst is in a premenopausal woman, if the size of the cyst is 3 to 5 centimeters, then the best thing to do is wait and watch. If she doesn't have much of a symptom, whatever the size of the cyst is, the woman complains of severe pain, or there is rebound, there is guarding, her vitals are not stable, then there is no question of any conservative management. You will immediately have to go you'll immediately have to put in a camera. You'll immediately have to go for a surgery. Whether it is laparoscopy or open surgery, it depends on the skill of the surgeon or whatever the surgeon is more comfortable with. So if she's like our girl, she's 25 years old, she doesn't have severe symptoms, and the size of the cyst is 3 to 5 centimeters, what you will wait and watch. It is just a conservative management. If the size of the cyst is 5 to 7 centimeters, then you'd like to repeat an ultrasound. When will you repeat the ultrasound? 3 weeks, 6 weeks, 12 weeks. You want to know whether the size of the cyst is increasing. Now, this cyst is a clear cyst. Okay. You have examined that 3 weeks, 6 weeks, 12 weeks, the size is not increasing. This cyst is a clear cyst, just like we have mentioned, no solid components, nothing. Then again, you can give the option of waiting and watching, or you can try combined oral contraceptives. Combined oral contraceptives can be tried for, say, 3 months' time, and then you can repeat the scan. All right. If the cyst is more than 7 centimeters, then irrespective of her symptoms, you offer her surgery. Let us look at the question once more. It is a 5 centimeter cyst, unilocular, thin-walled, no solid components, no septations. Like we have mentioned, premenopausal girl, 5 centimeter, 5 to 7 centimeter. What do? You will repeat an ultrasound in 6 to 12 weeks to assess for resolution. When do you go for an immediate surgery and cystectomy? If the size of the cyst is more than 7 centimeters. When do you give OCPs to prevent further cyst formation? That is, you are doing a repeat ultrasound and you find that the size of the cyst has not increased. It is still 5 to 7 centimeters. You can try giving OCPs. Now, what if this, instead of this girl, instead of a 25-year-old, what if she was a 52-year-old postmenopausal woman? Then immediately you will have to go for a CA125 in a postmenopausal woman. You are going in for a CA125 and the CA125 levels come out to be normal. If the CA125 levels are normal and the cyst size is less than 7 centimeters, you have the option to wait and watch. But if the CA125 levels are raised, irrespective of the size of the cyst, whatever the size of the cyst be, you have to offer surgery. Even if the CA125 level is normal and the size of the cyst is 7 centimeters or more, then also you have to go for surgery. Okay, this is actually pretty clear cut. It may sound confusing, but it is very clear cut. You are given a woman. First of all, you look at the age of the woman. Whenever you have got a question with regards to ovarian cyst, the first thing that you look into will be the age of the woman, whether she is menopausal or premenopausal. Whether premenopausal or menopausal, she has got severe symptoms, surgery is your answer. If she is premenopausal, then you look into the size of the cyst. Less than 5 centimeters if the cyst is, then you have got the option to wait and watch. Between 5 and 7 centimeters, your option will be to repeat an ultrasound between 3, 6 or 12 weeks to assess for resolution. If it is more than 7 centimeters, go for surgery. Again, 5 to 7 centimeter cyst, you are repeating an ultrasound, same size, you have the option to give a combined oral contraceptives. Now coming to the postmenopausal woman, first of all, you check CA125. CA125 is raised, immediately go for surgery. CA125 level is normal, size of the cyst is less than 7 centimeters. You have the option to wait and watch and repeat an ultrasound after 6 to 12 weeks. Here, you got something called B signs and M signs. We discussed a few things with regard to, a few things were given in the question with regard to the ovarian cyst in the previous question, right? That the cyst was unilocular, there were no solid components. Now, B signs means these are benign features on ultrasound. The benign cyst with a benign cyst shows what is known as the B signs, and a cyst with malignant features will show what are known as M signs. Look at these cysts. The green one at the top, these 5 pictures are B signs. They're benign cysts. While the ones at the bottom, they're all features of malignant cysts. Look at this. This is an irregular solid tumor, right? There will be, sometimes there can be a hypoechoic solid area within the mass. And here, it has got at least 4 papillary structures. 4 papillary structures. And what is the thickness? What is the thickness of the structures? Look at this. The structures will be more than 3 millimeters, septations of more than 3 millimeters in size. And there may be papillary vegetations, like we said, nodular projections. And look at the size of the cyst is usually more than 7 centimeters. That is why we said, if you've got a cyst size more than 7 centimeters, you'll go in for a surgery. M sign, one of the most important M sign is the size of the cyst. The size of the cyst is more than 7 centimeters. And then here, look at the blood flow. Here, look, this is this part here, this is the cyst. And the blood flow is, the vascularity is towards the periphery. Here, this one here, this is a malignant cyst. And look at the blood flow. The blood flow is central. That is central rather than peripheral vascularity is indicative of a malignant ovarian cyst. Okay, is this clear? This has to be really, really clear, because they'll always give in the question. If you're asked a question on ovarian cyst, they'll definitely be telling you about some of the, at least some of the ultrasound features. If they're mentioning that there are papillary projections, look at the size of the projections. They're mentioning it is a huge cyst. Look at the size of the cyst. It has to be more than 7 centimeters. And if they're mentioning vascularity, if they're mentioning peripheral vascularity, it is more in favor of a benign cyst. And if it is a central vascularity, it is more in favor of a malignant ovarian tumor. All are correctly matched except. Now, these are all bodies that are seen in ovarian cysts. You don't have much of a choice but to mug up these things. But I believe you have studied this over and over, so you'll be able to get the answer. Where are samoma bodies seen? Samoma bodies are seen in serous tumors. What about Kohl-Exner bodies? Yes, they are seen in granulosa cells. Signet ring cells are seen in Krukenberg. And Walthardt cell rests are part of a Brenner tumor. What else is there? You've got something like Schiller dual bodies. Where are Schiller dual bodies seen? They are seen in endodermal sinus tumors. Then another one is Ringke's crystals, which are seen in Hylas cell tumors. And there are the hobnail cells, which are seen in clear cell tumors. All right. Kohl-Exner in granulosa cell. Samoma bodies in mucinous tumors. I'm sorry, samoma bodies in serous tumors. Signet ring cells in Krukenberg. Walthardt cell rests in Brenner. Schiller dual bodies endodermal sinus. Ringke's crystals in Hylas cell tumors. And hobnail cells in clear cell tumors. Okay. Now we'll look at a couple of surgeries. Hysteroscopy. What is hysteroscopy? Hysteroscopy is the process that is used for visualize the interior of the uterine cavity. You introduce a camera through the cervix into the uterus and you're able to see inside the uterine cavity. So whatever is there inside the cavity, you can see, like a septum. Yes, it can be seen. Asherman syndrome. We'll discuss a little bit more about Asherman syndrome in a later question. But Asherman syndrome is about intrauterine adhesions. Whatever is inside the uterus, you can see. TB endometritis, yes, you can see. What is adenomyosis? Adenomyosis is thickening of the uterine musculature, is a thickening of the uterine wall that you will not be able to see through a hysteroscopy. When is hysteroscopy done? It is done in a premenopausal woman, it is done in the early proliferative phase. Early proliferative phase. So, hysteroscope is, like we said, it is a small camera, and the diameter of the hysteroscope will come to around 4 millimeters. So, you should dilate the cervix to 4 millimeters before introducing the scope. Okay. And then there are certain media that are used. Certain media are used in hysteroscopy. If you are going for a diagnostic purpose, that is, you just want to see it is a diagnostic hysteroscopy you're performing, then the best media to be used is carbon dioxide. But if you're going for a therapeutic scopy, that is, you need a septal resection or you're trying to take out a submucous myoma via hysteroscope, then your medium of choice becomes glycine. Okay. In this case, the answer is adenomyosis. Now, how do you diagnose adenomyosis? Adenomyosis is diagnosed by a transvaginal scan. A 26-year-old nulliparous female, third degree uterine prolapse, no cystocele, no rectocele. How do you treat? Now, uterine prolapse, a pelvic organ prolapse is one topic where you have, it is basically, as far as the questions are concerned, not many questions are asked from this particular topic, except for, you know how POPQ classification is done. You will not be asked to classify, but there is something called POPQ classification, and the reference point is the hymen. This you have to know. And another thing that you need to know is there are so many surgeries. You don't have to know how the surgery is done or what it is, but you really have to know the names of the surgeries. Here they have asked for a 26-year-old nulliparous woman, a young nulliparous girl, obviously needing childbearing at a later time. How do you manage pelvic organ prolapse in a young nulliparous girl? In this stage, you'll go for a sling surgery or a cervicopexy. Again, another young woman, but she is a parous girl. She does not want children, but she wants to retain her menstruation. In this case, you'll do what is called a Manchester surgery using or a Fothergill's. Fothergill's is actually the name of the stitch. What is it? It is in this where you go for an amputation of the cervix, cervical amputation. So you've got two surgeries, mainly in young women. A nulliparous woman who wants childbearing, you go for sling surgery or cervicopexy. A young parous woman who wants to retain her menstrual capacity, you'll go for a Manchester or a Fothergill surgery with amputation of the cervix. Look at the choices. Nulliparous girl, third degree prolapse. Just go for this. It doesn't matter what prolapse she has. She's 26-year-old young girl. Nulliparous, what is the surgery? Either a sling or a cervicopexy. Here from the choice, you've got abdominal sling surgery. Now we've discussed with regard to young nulliparous women. What about older women? An older woman, I'm certain you've seen surgeries that are being done for prolapse. Which is the most common surgery that is done for prolapse? It is a vaginal hysterectomy, or what is called a Ward-Myos vaginal hysterectomy. Ward-Myos vaginal hysterectomy is done in older women. See, suppose this woman, whether she's young or old, a woman who refuses surgery, she does not want a surgery, or she has got some kind of medical contraindication for surgery. In that case, again, you look at her age. She is a young woman. You can always give her a vaginal ring pessary. If she is an old woman, she cannot undergo surgery. That stage, you can offer colpoclysis. Right? What if the woman has got prolapse during pregnancy? after while she's in the second trimester, naturally, as the uterus grows upwards, the cervix will be pulled up, the prolapse will come down, the symptoms of prolapse will reduce. But during early pregnancy, you really have to treat her. If she has got a prolapse during pregnancy, the only thing you can offer her is a vaginal pessary. But if the cervix is already out, the cervix becomes incarcerated. In that stage, you will have to terminate the pregnancy. Okay. So this is with regards to the prolapse of the uterus. Young nulliparous woman, young parous woman, older woman, any woman who refuses surgery. I hope this is clear to you. Actually, there is nothing much. You just have to know the names. Okay. Now, another thing is with regard to the cystocele and the rectocele. Cystocele and rectocele also, you know, a cystocele and the urethrocoele. That is the upper 1/3 and the lower 2/3 of the anterior vaginal wall. Cystocele, urethrocoele. What is it that is done? It is an anterior colporrhaphy. Mostly whenever you're doing a vaginal hysterectomy, if you have looked at the surgeon's notes following, I think when you're house surgeons, you will have been the ones who probably wrote the notes for your teachers. So in that case, you'll definitely be writing VH plus PFR. What is PFR? It is a pelvic floor repair. Whenever a pelvic floor is repaired, PFR comprises of an anterior colporrhaphy and a posterior colpoperineorrhaphy. Anterior colporrhaphy is to repair the cystocele and the urethrocoele. And if she's got a lax perineum with the rectocele, you'll have to go for a posterior colpoperineorrhaphy also. What if she has an enterocele? What if she's got an enterocele? If she has got an enterocele, there are two ways in which you can repair. Either it is repaired abdominally or vaginally. Abdominally, the surgery is called the Moskowitz repair or the Halban's repair. And if you're doing it vaginally, the surgery is a McCall-Kuldoplasty. Okay, this is, I know this seems like a lot, like I said before, but this is actually not a lot. These are things that you know. Usually you must have seen surgeries being done for prolapse in older women. What is done? VH, vaginal hysterectomy with anterior colporrhaphy with posterior colpoperineorrhaphy. Anterior colporrhaphy is for cystocele, urethrocoele. Posterior colpoperineorrhaphy is for a lax perineum and a rectocele. Then usually these days, whenever vaginal surgery, vaginal hysterectomy is done, most of the surgeons will also be doing a McCall-Kuldoplasty, which is for the repair of the enterocele. If the enterocele is repaired abdominally, it is a Moskowitz or Halban repair that is done. Okay. Now, abdominal sling surgery for a young nulliparous woman. Whom do we do a colpoclysis for? We have mentioned this before. For an older woman who refuses surgery, you'll go for a Lefort colpoclysis. Fothergill's repair and amputation of cervix, again, it is done for a young woman who does not wish to conceive anymore, but does not want to lose her uterus. She wants to preserve her menstrual functions. Okay. A 32-year-old patient attends the infertility clinic. This is with, now we come to fertility. Fertility is another important topic for your exam. Attends the infertility clinic with regular cycles of 28 days, regular cycles. What should be evaluated for confirming ovulation? Whenever you get a question that says that the woman has got regular cycles, in all probability, she is having regular ovulation also. But still, she's attending your infertility clinic. She's 32 years old. So definitely you have to evaluate her. What are the common causes of female infertility? What are the causes of infertility? Infertility may be female causes, male causes, and both. So when you talk about female infertility, what are the common causes? The most common cause is anovulation. And the second one is a fall in the ovarian reserve. So these two are the important causes. First of all, we'll take anovulation. How do you test for anovulation? Like I said before, the first test is the woman has got irregular cycles. Here she has regular cycles. She'll be in all probability ovulating. So that is the first one. Then other things include a basal body temperature. You have studied this, right? Body temperature will increase on the day of ovulation under the influence of progesterone. Then we have got the cervical mucus test. There is ferning pattern of the cervical mucus under estrogen, under the influence of estrogen before ovulation. And then there is stack, that is the mucus becomes thick after ovulation, thick and easily breakable after ovulation. That is a cervical mucus. Then you can study the vaginal cytology. Yesterday we have mentioned with regards to maturation index, where there will be a predominance of the intermediate cells under the influence of progesterone at the time of ovulation. Then you can study the hormone. Which is the hormone? The hormone is progesterone. That is what is mentioned here. What should be evaluated? It is progesterone that is evaluated. When is progesterone evaluated? Actually, you can evaluate progesterone on 2 days. That is on the 8th day and on the 21st day, where you should be seeing a huge rise in progesterone with compared to rise in progesterone on day 21 as compared to day 8. So if you're asked a single question, what should be evaluated? Which hormone? It is progesterone at 21 days. Another thing that you can look for is an endometrial biopsy. If you're doing an endometrial biopsy, you will be able to see subnuclear vacillation. Subnuclear vacillation at ovulation. But none of these are the most common ones. The most common test that is used for ovulation is a serial ultrasound. Serial ultrasound that can be done, which will show a collapsed follicle and free fluid in the pouch of Douglas. All right. And yesterday, there was something else that we studied with regards to ovulation. You can do an ultrasound of, when you do an ultrasound, you look at the endometrium. Here, we had mentioned what, as far as the ovaries are concerned, you will be able to see a collapsed follicle, free fluid in the pouch of Douglas. What about the endometrium? The endometrium will show a trilaminar pattern. We saw this yesterday, did we not? The endometrium will show a trilaminar pattern. So these are the ones you don't have to study all this. A few of these you already know, like basal body temperature, like cervical mucus, vaginal cytology. What is important for you is, first one is the hormone. Which is the hormone? It is progesterone. It is studied at day 21. What is seen on endometrial biopsy? It is subnuclear vacillation. This one you need to know. Subnuclear vacillation you need to know. What is seen on serial ultrasound? Actually, on serial ultrasound, this is the important thing you need to know. The endometrium will have a trilaminar appearance. So these three things you have to know with regard to a test, as far as your exams are concerned, for a test confirming ovulation. All these three you need to know. Now, the second common course was ovarian reserve. What are the tests for ovarian reserve? Again, a couple of things you need to know. Tests for ovarian reserve. You always say one of it is age, but sometimes the age of the ovary may not always correspond with the chronological age. So you cannot give much importance to that. The best test for ovarian reserve is anti-Mullerian hormone plus the antral follicle count. This is the best test. But usually this is not given in the choice. So the single best test, if you're asked to do, you're asked to pick a single answer, then you have to go for anti-Mullerian hormone. Okay, these are the tests for ovarian reserve. Now you've got a 23-year-old woman. She is accompanied by her mother-in-law. She came to the infertility clinic. She has been having regular intercourse for 6 months, but is not able to conceive. What is the next step in line? Usually, you say that a couple has, remember, a couple has, not a woman, a couple has primary infertility if they have been trying to conceive for 1 year and they have not been able to conceive. But these days, we will evaluate for infertility if they come after 6 months' time. Now, they say she has been trying regular intercourse for 6 months. She's not able to conceive. What is it that you should do? Reassure and see her after 6 months. Why? That choice is important because, like I said before, it is 1 year that you use to define infertility. But if the woman comes to you after 6 months, you should start evaluating her then and there. You cannot ask her to come after 6 months. So you cannot pick that choice. Will you immediately go for a histolab or hysteroscopy? Both are part of evaluation for infertility in a woman. But before all that, the next step in line, whenever a woman comes to the fertility clinic, is to ensure that before you go for an invasive test for the woman, you should ensure that her partner is absolutely normal. So the next thing that you do is a semen analysis for her husband. If needed, you will have to treat her husband first before treating the woman. Okay. I'm not going into the details of semen analysis. I believe you know that. Just go through it immediately. I mean, like we talked about the FIGO staging, go through it just prior to the exam. The most important criteria in semen analysis is the sperm morphology. The sperm morphology of the sperm, where you need at least 4% sperms to be normal. As soon as you see this ultrasound picture, you should arrive at your answer. I am sure you have seen this ultrasound several times. A 24-year-old woman, she's being treated for infertility with HMG. What is HMG? HMG is human menopausal gonadotropin. She comes with complaints of sudden abdominal pain, nausea, vomiting, breathlessness. Ultrasound shows the following. What is your diagnosis? Yesterday, when we talked about PCOS, we talked about certain complications of pregnancy that are associated with PCOS. One of them was OHSS. What is OHSS? Ovarian hyperstimulation syndrome. When this usually seen in women who are being treated for infertility, especially when they are getting gonadotropin injections, as in this case, human menopausal gonadotropin. What are the things that you need to know? What is the main pathological factor? Main factor is an increase in vascular endothelial growth factor, increase in VEGF. And it leads to, there is hemoconcentration. Why? Because there is loss to the third space. There is electrolyte imbalance. There is increase in the ovarian size. This is more commonly seen. The risk factors include a young woman, a young girl with PCOS who has been receiving gonadotropin injections HCG or HMG. Okay. So this is the ultrasound. Look how big the cysts are. You have to differentiate from a PCOS. In PCOS, the cysts will be 2 to 9 mm in size, 2 to 9 mm, mostly peripherally arranged. In OHSS, that is not the case. Look how big the cysts are. Sometimes you may get a question like a woman has undergone a TVOR. That is another word you need to know. TVOR is a procedure that is done in infertility before IVF. This is transvaginal oocyte retrieval. The woman may present with in the same case. Again, you should go for, your answer will be OHSS. Okay, instead of saying HMG, they may say immediately after TVOR. Don't doubt it. It is the same thing. Transvaginal oocyte retrieval. Again, the woman may come with ovarian hyperstimulation syndrome. An azoospermic patient can father a child by which of the following? What is azoospermia? Azoospermia means there are no sperms in the semen. No sperms. A person who does not have sperms in the semen, how can this particular person father a child? In this case, as far as male fertility is concerned, in the treatment of male fertility, there are 3 different things. That is, this person can conceive only by either by IUI, intrauterine insemination, or by IVF, in vitro fertilization, or by ICSI. What is ICSI? Intracytoplasmic sperm injection. These are all done in cases where the sperm count is low. IUI is actually, what is the normal sperm count? It is say 15 million per ml. 15 million per ml is the normal sperm count. IUI is done when the sperm count is 10 to 15 million per ml. What about IVF? What is in vitro fertilization? In vitro fertilization, 50,000 to 1 lakh sperms are introduced per oocyte. 50,000 to 1 lakh. This is done when the sperm count is 5 to 10 million. And ICSI, where there is 1 sperm per oocyte, this is done when the count is less than 5 million. So if the man is azoospermic, there are no sperms at all, how can he father a child? by ICSI when the count is less than 5 million per ml. You will not be able to get sperms from the semen in this case. So then you'll have to go for a testicular or epididymal sperm extraction and then perform ICSI. Okay. Male fertility treatment here, as I've mentioned here, quite easy. 15 million is the normal count. Less than 15, that is 10 to 15 IUI, 5 to 10 IVF, less than 5 ICSI. Okay. Azoospermia means no sperms, definitely less than 5. What is it? It is ICSI. Now let's look into contraception. The non-contraceptive uses of OCPs, oral contraceptive pills, include all the following except. You're all familiar with OCPs. You know how OCPs are given. You know what the components are. So just a couple of things. What are the non-contraceptive benefits? So I've always studied it this way. Benefits of OCPs. B, standing for benign fibrocystic disease. E, for ectopic pregnancy, protects from any pregnancy, and in that, in the meantime, ectopic also. N, for neoplasm. What neoplasms? Ovarian or endometrial neoplasms. E, again, for endometriosis. F, for fibroids. I, for iron deficiency. Why iron deficiency anemia? Because oral contraceptive pills will reduce the menstrual flow. Iron deficiency anemia, and irregular cycles also. You know that they regularize the cycles. Then T, it's for premenstrual tension syndrome. S, for sickle cell disease, sickle cell anemia. And then you've got osteoporosis. And P for PID. Okay. See how it reads? The benefits of OCP. If you've got another mnemonic for this, you can use that one also. I just mentioned what I use. The non-contraceptive benefits. Benefits of OCPs: benign fibrocystic disease, ectopic pregnancy, neoplasm, ovarian or endometriosis, fibroids, iron deficiency anemia and irregular cycles, premenstrual tension syndrome, sickle cell anemia, osteoporosis, and PID. Look at the choices. Reduction in risk of ovarian cancer, yes. Neoplasm of the ovary. Ectopic pregnancy, yes. Reduction in risk of endometrial cancer, yes. Do they protect against sexually transmitted diseases? No. So which is the contraceptive method that protects against sexually transmitted infections? The only one are the condoms. The barrier contraception is the only one that protects against sexually transmitted infections, all sexually transmitted infections. A female is on Mala N for contraception. After the end of the first strip, there was no withdrawal bleeding. What should be done? Definitely, after using oral contraceptive pills, whatever it may be, whichever generation of progesterone it is, they will definitely need to get a withdrawal bleed. This woman has not got a withdrawal bleed. What is it that should be done? The first thing that should be done is she should check for pregnancy. Before she starts the next cycle, before taking 2 pills, before anything else, she should visit the hospital urgently to check for a pregnancy. When is copper T contraindicated? Like I said before, I've got another mnemonic for this one also. What I use is wash the cup, where W is for Wilson's disease, trophoblastic disease, and then you've got C. C may be for copper allergy, carcinoma of the breast, the uterus, or the cervix, cervicitis. U is for uterine distortion, or fibroids, uterine fibroids, and P for puerperal sepsis, for pregnancy, or for postpartum endometritis. Do you get it? Wash the cup. Again, I'm telling you, this is just my mnemonic. You've got another one. Please use it. Don't mug up this one. Wilson's disease, trophoblastic disease, copper allergy, carcinoma of the breast, uterus, or cervix, cervicitis. U is for uterine distortion, uterine fibroids, and P for puerperal sepsis, pregnancy, or postpartum endometritis, right? So in this case, copper T is contraindicated in trophoblastic disease. Which of the following statements is incorrect regarding LNG-IUCD? What is LNG-IUCD? Levonorgestrel IUCD. It is called the Mirena. Mirena is the one that we commonly use. There are quite a few in the market now. What does it do? Now, this can be used as a hormone replacement therapy in women needing progesterones. Okay. Now, and it is one of the most important things that is now used in the treatment of endometrial hyperplasia. Actually, Mirena or LNG-IUCD has helped a lot, has brought down hysterectomies to a large extent. And it can cause irregular spotting, irregular uterine bleeding, but it will never cause an increased incidence of menorrhagia. Basically, the bleeding will come down to a large extent in women who are using LNG-IUCDs. So that is with regard to multiple choice questions. We'll just look at a few slides, a few pictures before we wind up. Okay. What is this? Do you know what this is? These are, look at these. These are vaginal epithelial cells. They're all vaginal epithelial cells, but they've got something sticking to it. They are vaginal epithelial cells with attached bacteria. What are these called? These are called the clue cells. Clue cells. Where are the clue cells found? In bacteria vaginosis. Regarding bacterial vaginosis, this is the most common vaginitis. This is not a sexually transmitted infection. So if you're getting a question regarding bacterial vaginosis, know that there is no need to treat the partner. You have to identify the clue cells. It is found in bacterial vaginosis. What is the investigation of choice? Investigation of choice is saline microscopy. This here, the picture shown here is one of gram staining. Gram staining, which is a gold standard investigation. The gold standard investigation where you will be able to see the clue cells. What is the other thing that you need to know? That is the Amsel's criteria. I will not go into the details. You know this one. Vaginal discharge, Biff test, clue cells, and pH of more than 4.5. That is the Amsel's criteria. What is the drug of choice? It is metronidazole. So these are the only things you need to know with regard to bacterial vaginosis. Clue cells, investigation of choice, saline microscopy, gold standard, G for G, gold standard, gram staining. Then you've got Amsel's criteria. Drug of choice is metronidazole. This is not a sexually transmitted infection. No need for partner treatment. Yes, we have discussed this quite a lot of times. What is this that you see here? This is the ferning pattern, ferning of the cervical mucus. Ferning pattern seen where? Ferning pattern seen under the influence of estrogen. It starts on day 8 and disappears by day 18. What are the other conditions? That is the important thing. There is one other condition where you will be able to see ferning. That is it. It is also seen in PROM or PPROM because of the presence of sodium chloride. Okay. This is ferning. You're easily able to identify the fern pattern, right? Another one. Again, this one also, you know, what is this? Seen in PCOS patients mostly. This is acanthosis. What is this a clinical manifestation of? Clinical manifestation of insulin resistance. Yes, another one. This one here is a hysterosalpingogram. Hysterosalpingogram is when you inject a dye through the cervical canal into the uterus. Normally, you will see that the dye spills into the peritoneal cavity. Here, the dye is not spilling. I've been saying dye, which is a common dye used. Do you know the name of the dye? Dye is urographin, okay? I doubt whether this will be asked, but just keep it in mind. The dye is urographin. Anyway, in this case, you find that the dye has spilled into the tubes, but has not spilled out into the peritoneal cavity. It is actually, the tubes have actually got a pouch-like appearance. This is called a tobacco pouch appearance, which is a feature of genital TB. So this is a hysterosalpingogram of genital TB with tubes showing a tobacco pouch appearance. You have to know the most common site of genital TB are the tubes. What is the most common symptom? Most common symptom is infertility. As you see, the tubes are blocked. So the most common symptom is infertility. If you are asked what is the most common menstrual symptom, then it is polymenorrhea. You get this question and you are not asked what is this. You may be asked, a woman HSG has been, a woman presents to a 25-year-old woman presents, HSG has been done, and this is the picture. What is the most common symptom, or what will she have presented with? The most common symptom is infertility. All right. Most common menstrual symptom is polymenorrhea. What about the most common PV finding? The most common PV finding is an absolutely normal PV finding. She may have adnexal tenderness, okay? But HSD is not the investigation of choice. The investigation of choice is endometrial biopsy. Investigation of choice is an endometrial biopsy, which is done in the premenstrual phase. A woman presenting like this with infertility, how do you treat? Her tubes are completely blocked. In this case, the treatment of choice is in vitro fertilization, IVF. Next picture. Here, you find that the uterine fundus is divided into two. That is, there are two uterine horns and there is only a single vagina. What is this? This is a Mullerian anomaly. This is a biconvate uterus. Two horns with a single vagina. If you're doing an HST, like previously, if you do an HST, you will find that there is an obtuse angle between the horns, and the horns will be separated by more than 4 centimeters. Why this is important? HST, you will have to differentiate from a septate uterus, which will have an acute angle between the horns with a distance of less than 4 centimeters. Anyway, I think this will not be difficult for you. You will be able to identify a biconvate uterus on an HST. Another picture that I'm certain you have seen several times before. This is a violin string appearance. Look, the violin string appearance. What is this? This organ here, this one here, this is the liver. And this here, this is the anterior abdominal wall. You see there are so many adhesions between the liver and the anterior abdominal wall. This is the Fitzhugh-Curtis syndrome. Fitzhugh-Curtis syndrome. Fitzhugh-Curtis syndrome is most commonly caused by, most common organism that is responsible is chlamydia. But if you're asked, what is the most common organism that causes an acute or a symptomatic Fitzhugh-Curtis syndrome, then your answer changes. It is gonorrhea. What about in postmenopausal women? It is E. coli. So many organisms that cause it. If the woman is an intrauterine contraceptive device user, then the organism is actinomyces. And if it is a virgin, then the organism is TB. Now, in all these cases, this is a sexually transmitted infection. That is, this is an ascending infection, except in a virgin girl, except in TB, where this is a hematogenous infection. You will not miss this. There is no way you can get this wrong. Violin string appearance with the liver being adherent to the anterior abdominal wall. The Fitzhugh-Curtis syndrome, most common organism is chlamydia. This one we had discussed before. What is this? Asherman syndrome. This is the hysteroscopic appearance. You have put in a camera from below. This is what you see. There are so many adhesions. This is Asherman's. Asherman syndrome or intrauterine adhesions. The typical clinical feature is hypomenorrhea, less bleeding, because there is no healthy endometrial tissue inside. What is the most common cause? Most common causes, obviously, you know that it'll have to be some intrauterine procedures that are done. The most common cause is B and C, which is done for PPH, postpartum hemorrhage. So the woman will present with hypomenorrhea after childbirth. She'll give a history of postpartum hemorrhage and some procedure being done. Your answer is Asherman syndrome. Okay. And the investigation of choice, both the investigation of choice and the treatment of choice are both hysteroscopy. Investigation, you look at it, and the treatment of choice is a hysteroscopic adhesiolysis. Okay, that is Asherman syndrome. It is very, very unlikely that you'll get pictures wrong in gynecology. Gynec pictures are pretty easy, except for histology, except for pictures from histology. Here again, this is a contraceptive. The name is given there. This is Implanon. Implanon is a single rod. Single rod. This is the most popular progesterone only implant. Progesterone only. The importance of a progesterone only implant is that this can be used immediately postpartum also. You know that combined pills or estrogen and progesterone containing implants are contraindicated postpartum. This can be used immediately postpartum. It consists of etonogestrel, 68 milligrams, and it has got a lifespan of 3 years. Now, this has got no effect on lactation, no effect on bone mineral density, carbohydrate, or lipid metabolism. But remember, just like we mentioned in the case of oral contraceptive pills, this one also, it will not give any protection against sexually transmitted infections. Okay, the only thing that can protect from sexually transmitted infections are the barrier contraceptives or condoms. What is this here? This is a colposcope, which is now the gold standard for evaluation of abnormal cervical smear. Before it was cornization or corn biopsy. And if colposcope is not there, it has to be again cornization, corn biopsy. This is a colposcope. This helps in the examination of the lower genital tract and anus. That is, it will give around 5 to 30 times magnification. Also, the problem with the colposcope is that the upper 2/3 of the cervix cannot be seen. The rest of it can be seen. You will know this instrument is the colposcope. This one, very common, very easy. What is this? Ovarian cyst. Which cyst is this? This is a dermoid cyst or a mature cystic teratoma. What is the importance of a dermoid cyst? It contains elements from ectoderm, from endoderm, and from mesoderm. The most common element, what is definitely seen, look, the hair. That is, ectodermal elements are the most common. Ectodermal elements are the most common. So, if you're asked what is the most common carcinoma that can occur in a dermoid cyst, since ectodermal elements are common, the epithelium is a keratinizing squamous epithelium. In a keratinizing squamous epithelium, the most common carcinoma that can occur is a squamous cell carcinoma. Okay, these are the things that you need to know. Then, so if you take an ultrasound, you will be able to see an area of localized growth. Localized growth means it may be hair or teeth or bone. This is called the dermoid process. The dermoid process, also known as the Rokitansky protuberance. There are a few names here, named terms here, but I think compared to all the other subjects, Gynec comes with very less number of named terms. As sir said yesterday, this is quite an easy subject. It is a very high scoring subject, and if you just brush through, you will be able to get almost all the questions right. And these are I've just included one histological picture. Please go through a few others, all with relation to ovarian cancers, ovarian tumors, and others in the phases of the menstrual cycle also. These are the couple of histology where you will need to concentrate. Here, this is an easy picture. What you see here, this one here, look how it is shaped like a ring. See, again, you have this here. So many cells that are shaped like rings. These cells are filled with mucin, and the nucleus is pushed to the periphery. This is seen where? in Krukenberg tumor. What is the name of these cells? We have discussed this before. They are signet ring cells that are seen in Krukenberg's tumor. Krukenberg's tumor, you know, it's a secondary tumor. The most common primary, I'm just discussing the associated question. The most common primary is the carcinoma of the pyloric end of the stomach, carcinoma of the pylorus. 80% of Krukenberg tumors are bilateral, where the ovaries will retain their shape. Okay. So that is it from my side. I hope you have had a productive couple of hours. Okay, I'm sorry we had to take it over over a couple of days anyway. Now, you know that it's crunch time now. You should get all your priorities straight. You have to set your timetable. You have to stick to your timetable. And when you approach a question from whichever subject it may be, gynec or any other subject, you focus on the question. You have, make sure your mind is clear. You focus on the question, and please don't second guess. Your first answer will always be your best answer. And do not doubt yourself. I know it is easier said than done, but keep calm. Always remember that there is a way. All the very best for your exams. Thank you so much. Thank you.